Reducing the length of stay of orthopedic patients in the post-anesthesia care unit by Beth Weslow. Post-anesthesia care units, PACUs, also referred to as recovery rooms, were introduced in 1923 and since then have been the predominant setting for patient recovery immediately after surgery. A patient's length of stay in the recovery room is determined by many factors, including the type of anesthesia being used, the type of surgery being performed, and the preoperative health factors of the patient. Time spent in the PACU is recognized internationally as a time of increased risk to patient safety. Physical deconditioning and risk of fall post-anesthesia are common. Our goal was to identify factors that delay the transfer of orthopedic patients from the PACU to the medical surgical floor in an attempt to reduce the length of stay and safely transfer the patient to the next level of care. An appropriate PACU length of stay is defined as the time required for a patient to achieve a physiologically stable condition after anesthesia administration. Postoperative patients have been shown to return to baseline in approximately 120 minutes. Total joint replacement also represents the single largest cost center for the Centers for Medicaid and Medicare Services. An increased length of stay also has an economic impact on healthcare facilities. The staffing cost for a 2-hour PACU stay is roughly equivalent to the staffing cost of a 24-hour stay on a hospital ward. Our team decided to implement an intervention to reduce the orthopedic patient's length of stay in the PACU down to 90 minutes. Patient-specific factors that cause a delay in being discharged from the PACU are pain, conscious state, blood pressure, nausea, and vomiting. There is no validated scoring system to determine a patient's readiness for discharge from the PACU. The Aldrete system is widely used. It measures oxygen, consciousness, circulation, respiration, and motor activity. This tool has been used universally since the 1970s, up until 1995 when the criteria was modified to accommodate patients that were going home after surgery, now known as same-day surgery. Our nurses have to use their clinical judgment along with the modified Aldrete scoring system to determine patients' readiness for discharge. Non-patient specific factors that cause delay in patient transfer from the PACU to the medical surgical floor is sign out by anesthesia, bed availability, obtaining post-operative x-rays, and hospital transportation of the patient out of the PACU to the medical surgical floors. Prior to my arrival in the PACU, our department had addressed anesthesia sign-outs, post-operative x-rays, and hospital transportation by implementing interventions and conducting PDSA cycles, and they did show some improvement in the length of stay with the orthopedic patients. Anesthesia attendings are now contacted within 45 minutes of a patient's arrival to the PACU after the OR to alert them of potential discharges of patients that meet criteria determined by the Aldrete score that the nurses use. All post-operative x-rays, which are required after total joint replacement, are now done portably to decrease wait time and delay in any results. Our department now has PACU transporters, people that are specifically assigned to our area and that do work overlapping shifts to prevent any delays. So the PACU staff, our unit manager, bed coordination, and the staff of the orthopedic medical surgical floor work together to implement an intervention and a PDSA aiming to reduce the length of stay with the pre-assignment of beds for joint replacement patients for Surgeon A and Surgeon B. So our plan was that the administrative control clerk, the ACC, also known as a ward clerk, on the orthopedic floor would send the PACU staff the bed assignment via bed tracker or fax no later than 8 o'clock in the morning for both Surgeon A and Surgeon B's patients. The PACU staff will notify the patient and family of the bed assignment and direct them to the floor. A bed assignment welcome note was developed and in the PACU and given to the family and patient upon arrival into the pre-op area. The PACU staff had to be educated on the process for this. The process included, in the pre-op area, giving the patient and family the bed assignment. These patients were coming to stay and they knew they were coming to stay, so they would bring suitcases and personal belongings. After the patient left the pre-op area, the family was encouraged to go to the orthopedic floor, to the room, which were all private rooms, and to take their belongings with them, which they could safely leave them into the rooms. After that, they were directed to come back down to the surgical waiting room. That way, they could speak with the surgeon after the surgery was done. And after that, they were directed to go back to the floor and wait in the room for their loved one to arrive. We did, after studying this, we implemented it, taught the staff. It seemed to go pretty well. We did have a little bit of a snag of patients and families being notified of room assignments while still in the pre-op area because there was at times limited bed availability. So we decided to identify factors that caused the delay in the bed assignments, and we just modified our intervention as needed. Our PDSA did show improvement and consistency for the orthopedic surgeon A, and our goal was not only met, but it was broken. Prior to the PDSA being implemented, Surgeon A's patients had an average length of stay of 107 minutes after reviewing 23 patient charts. We ran the first PDSA cycle. Um, we not only showed improvement, but our goal was met and had an average length of stay of 89 minutes below our goal of 90 after we reviewed 25 patient charts. We ran a second PDSA cycle, and we continued to show improvement with Surgeon A's patients having an average length of stay being 80.55 minutes after reviewing 20 patient charts. Though improvement in length of stay was shown in the data for Surgeon B, uh, we did not meet our goal of 90 minutes. Prior to the PDSA implementation, Surgeon B's patients' average length of stay was 124 minutes when we reviewed 28 patient charts. We did get that number decreased down to 118 minutes for the length of stay after our first run cycle and reviewing 59 of that surgeon's charts. We did continue to show improvement after the second PDSA cycle. We were able to get the patient's length of stay after reviewing 42 charts down to 112 minutes, but we still did not meet that 90-minute mark for Surgeon B. I did do a review of charts just to eliminate some patient-specific factors or factors that we may not have thought of at the time. Research evidence had suggested that hypothermia could be a potential cause for an increased length of stay of patients in the PACU. No evidence of this was found upon review of the patient's charts that did have increased lengths of stay. Other research evidence suggests that patients with a stronger sense of coherence experience less pain and consume less opioids. A patient's sense of coherence and attitude prior to surgery can affect postoperative complications. In the cases of both of our surgeons, their patients are having an elective joint replacement or a revision of a previous joint replacement. There is some degree of anxiety prior to surgery, and that is to be anticipated on the patient's part, but these patients are medically cleared and optimized to have such a surgery, compared to patients on our hospital's other orthopedic service that treat acute traumatic non-elective procedures. There were a couple instances that were out of our control as far as patient-specific factors were concerned, as far as pain or nausea. There was a couple incidences and delays being caused by late sign-outs by anesthesia, transportation, x-ray, but nothing that overall affected our intervention of the pre-bed assignment. Bed availability appears to be the biggest barrier to Surgeon B's patient's length of stay. The data does show that pre-assignment of beds works well on Mondays and Tuesdays, but there's a delay on Wednesdays. So we did take measures to improve communication between the PACU and the bed coordinator when the hospital census was at capacity in order to keep the patient and family informed. We did mention this to Surgeon B, and he did agree that more research would have to be done to determine if the delay in discharge of the patients on the floor, at least as far as the orthopedic patients that possibly came in on Monday that weren't being discharged by Wednesday, was it patient related, Was it nursing staffing related, discharge ride availability, or another factor that we're not thinking of? And even though there were some inconsistencies with providing the patients and families the bed assignment in the pre op area, positive feedback was received from the patients and their families with the pre assignment of the beds. It gave the family a sense of control and a sense of comfort. They knew where they were going to be going after waiting all day long after these surgeries. The families were instructed that after speaking with the surgeon after the surgery was done, the family was directed to go up to the room to wait for the patient to arrive. This gave the family the opportunity to familiarize themselves with the floor. It also gave them an opportunity to meet the staff that would be caring for their loved one. And it gave the staff the opportunity to start the education process for the family regarding post operative care and the discharge process. Positive feedback was received from both surgeon A and B. They appreciated the efforts that were put forth to try to have better outcomes for their patients. And the PACU staff did have a nice sense of collaboration and a sense of accomplishment. I hope you enjoyed listening to this presentation as much as I enjoyed reviewing all this information to try to reduce the length of stay of orthopedic patients in the post anesthesia care unit. Thank you.